We are now in Unit 4. In this unit, we're going to cover blood and wound cultures and related organisms. In Unit 3, we talked about the family of organisms known as the Enterobacteriaceae. So now we're going to talk about kind of a different group of gram-negative rods known as the non-fermenters, and then at the end there will be some information on some miscellaneous gram-negative rods. This first lecture, we're going to cover blood and wound culture, so this should be a fairly short lecture, I believe. Okay, blood cultures. So we use blood cultures to detect the presence of bacteria, virus, parasites, or yeasts in the blood. We want to be able to identify any microorganisms present and then send out a report that helps guide treatment for the doctor. So just a little bit of terminology. Bacteremia, which you guys have heard that term in previous lectures, but it just refers to presence of bacteria in the blood. Septicemia is an older term that's not as widely used anymore, according to the book anyway. In clinical practice, you probably will hear the term septicemia, but it refers to bacteremia in conjunction with a clinical presentation of physical signs and symptoms of bacterial invasion and toxin production. So this term is still used clinically, like I said, and in the collection of epidemiologic data on causes of death. However, due to its imprecision in defining a disease state, it's been largely replaced with systemic inflammatory response syndrome, or SIRS. So this is the newer term to replace septicemia. It identifies a spectrum of conditions that relate to the inflammatory response caused by bacteremia. The risk of death increases as the patients move along this continuum. So the first part of that is a non-infectious inflammatory response. That moves on to sepsis, which is the infection including a systemic inflammatory response. Then the patient moves into the stage known as severe sepsis, where you have sepsis accompanied by organ dysfunction, hypotension, which is low blood pressure, or tissue hypoperfusion, where you have circulatory failure, so failure of fluids to circulate to the tissues. And then the final stage of that continuum is septic shock, where you have sepsis including refractory hypotension. So refractory is just kind of a term used to mean when something is not responding to treatment. So this would be the patient has hypotension, not responding to treatment. Okay, so a lot of hospitals now have what they call sepsis protocol. And this is where if you have a patient that presents to the ER with a specific set of symptoms, then that means certain testing would be initiated. So some of the symptoms of sepsis include chills, fever of unknown origin, and that's what FUO stands for. But that's fever of unknown origin, that's kind of like the critical part there, because if a patient comes in and they have the flu or they have strep throat, and they have a fever, we know that, or we know what the cause of that is. But fever of unknown origin, so the patient has a fever and we don't know why. Nausea, rapid breathing, rapid heartbeat, confusion, decreased urine output. So if the patient comes in and presents with all or some of those symptoms, then they're going to initiate this sepsis protocol. So some of the more common tests ordered in conjunction with the blood cultures as an indicator of sepsis are lactate, procalcitonin, and CRP. CRP stands for C-reactive protein. To collect the blood cultures, the skin has to be prepped a little bit differently from a normal blood draw. So it would be cleansed with 70 to 95% ethanol or isopropyl alcohol solution, and then cleansed with a 2% iodine, which has to be left on the skin for 30 seconds. They have some, and I can't remember right now what they're called, but they have some different like little prep things that you use that are specifically for collecting blood cultures from a patient that cleans the skin properly. best case scenario is that you want to collect the blood cultures before administration of antibiotics, during fever if possible, and you want to collect at least 2 sets, sometimes as many as 3 or 4, just depending on what the doctor thinks might be the cause of the sepsis. So at least 2 sets, at least 5 minutes apart, preferably from different sites. So a blood culture set consists of an anaerobic and an aerobic bottle. So it's 2 bottles, or they do make pediatric bottles that are made, they're supposed to be for pediatric patients. They collect a smaller volume of blood. They do get used a lot of times, though, for adults if the patient is a particularly hard stick, they don't want to be stuck, if the blood stops flowing. Just if the phlebotomist knows that they're going to have a hard time collecting that sample, you can also collect a pediatric sample instead of the 2 aerobic and anaerobic, the set. Some additives that are in the bottles, SPS is the additive of choice, and it's already in the bottle. It functions as an anticoagulant. It neutralizes bactericidal activity of human serum. It prevents phagocytosis, and it can inactivate certain antimicrobial agents that may be present in the patient's blood. However, SPS is also known to inhibit the growth of certain organisms, but it's kind of the lesser of the evils. So the blood to broth ratio, 1 to 10 is optimal for overriding any antibacterial elements found naturally in the blood, such as white blood cells and complement. SPS can also help prevent phagocytosis and complement activation if that optimal blood to broth ratio cannot be achieved. And there's the sides of the bottles are kind of marked so that you know how much to draw into the tube. Incubation, so bottles are agitated and monitored continuously by a blood culture incubator system. So it's a special type of incubator that is made for the blood culture bottles so that it will incubate and kind of rock them or agitate them back and forth continuously. General rule of thumb is that we hold those bottles for 5 to 7 days, but we can hold them longer if the doctor wants them held for longer, if they're suspecting maybe a specific organism that takes longer to grow, or if different types of bottles, it might be the criteria for those different types of bottles might be that they are held longer. The agitation of the bottles serves to increase oxygenation in order to enhance the detection of microorganisms and decrease recovery time. So if the patient does have an organism in their blood, by constantly keeping those bottles rocking back and forth, it's just helping the chances that we will recover that organism. So the incubation system takes a baseline reading when you place those blood culture bottles into the instrument for the first time, and then also every 10 minutes after that. So if organisms are present, they're going to produce CO2 as a byproduct as they grow. That is what is detected there's a gas permeable sensor on the bottom of the bottle. So if there's a change in those subsequent readings, then the machine uses an algorithm to flag the bottle as positive. So negative blood culture bottles, which means that the incubator system has not detected an organism or flagged that bottle as positive. So negatives get reported automatically on a daily basis, and that's just through the incubator system is connected to the lab's LIS, and every 24 hours it knows to update that report on the negative bottles to say, okay, this one is negative at 24 hours. Now it's negative at 48 hours. Now it's negative at 72 hours, and it will do that until that 5 or 7 day has been met, and at that point it will finalize the report. If a bottle is flagged as positive, cultures and gram stains have to be set up. The gram stains get called as a critical or an alert value, and then those plates are incubated and worked up. And again, we put out that gram stain report because that's going to be done in, within an hour at the most, whereas those plates will take, it's going to be probably 12 to 16 hours before we will even be able to do a preliminary report on them. So that gets that report out sooner so that the doctor has something to base treatment on. Contamination in a bottle would be indicated if only one bottle of a set becomes positive. So if you have one bottle out of a total of 4 that were drawn, the likelihood of that organism being a contaminant is pretty high. However, even if it's an organism that would normally be considered normal flora or a skin contaminant, if it's recovered in all 4 bottles, then that patient might be immunocompromised. We would need to treat that as a pathogen. Some of the common contaminants are gram-positive rods and your coag-negative staph, micrococcus, but full sensitivity would be performed on all identified organisms that are considered pathogens. Some automation, so your BAC-T alert systems are kind of the incubator systems that are commonly used to hold those bottles and and test those bottles. Nucleic acid amplification testing can be performed on positive bottles to identify the organism in as little as 65 minutes. So you're still going to have to perform the cultures so that you have the organism to set up the sensitivity testing on. But if your lab has that nucleic acid amplification method of testing, which is just a molecular testing method, and a lot of labs have this available to them now, you can get that blood, that identification of that organism out within, a little over an hour versus having to wait for 48 hours to wait for the culture to grow and then to set the organism up on your microscan or whatever. So can be a huge help in treatment for the patient. Here's just an example, some different examples of different types of blood culture bottles that are available, and you can't, I can't read the labels on them, but I know for sure that the pink one is a pediatric bottle, but they make bottles for recovery of mycobacterium, for fungal elements. So they have different bottles that are kind of like our selective and differential media. The bottles would be made to recover certain organisms if the doctor suspected them. And then here's an example of the blood culture cabinet or incubator system. So, and this is an example of a BAC-T alert. There are 4 drawers on that instrument. So if you've collected a blood culture that you need to load into the instrument, you would come to the instrument, you would open one of these drawers, and then you would scan the bottle has a barcode on it itself, and then you would have a patient barcode. So you would scan both of those barcodes to tell the instrument that this particular bottle that belongs to this patient is going into the instrument, and then you load it into these slots. That picture's kind of hard to see, but on the next image here, so you've got all of these slots on the inside of the instrument that the bottles just slide into. So you scan it, you load it into the instrument. When you close the door, those racks that you see there will start kind of rocking gently back and forth again. For positive blood cultures, we have to inoculate our plates, so they make special devices that will fit onto the end of the blood culture bottles that allow us to inoculate the plates. And then here's a picture of the nucleic acid amplification testing, one of those type systems. This one in particular is called a BioFire. So you would inoculate these little testing strips there that come with the kit, load it into the instrument, and then it does its testing. And like I said, you get a result in about an hour. And each one of so they make these panels For positive blood cultures, they have a GI pathogen panel, a respiratory pathogen panel. So they have different cartridges for different tests and for different specimen sources. And each one of those panel types would test for different organisms. So the blood culture is going to test for, say, maybe 20 target organisms that are most commonly recovered from blood. The respiratory pathogen panel would test for different organisms that would be more commonly recovered in respiratory specimens. So, but all of those, again, you can get that result in about an hour. Okay, next we're going to talk a little bit about wound cultures. So wound cultures can come from any source on the human body. They can grow just about anything. So, and going back to a previous lecture when we talked about the importance of recording that specimen information, when you get the specimen in, if it's from if it's a wound specimen or it's for a wound culture, it is so important for us to know the source of that specimen, because that is going to determine what organisms we consider pathogen versus normal flora. So collection technique, the site should be cleaned properly. Specimens should be taken from within the affected area. So you want to be careful not to swab the surrounding area, which could lead to a contaminated culture. So an aspirate can be taken from certain types of wounds, like boils or anywhere where fluid is built up. It could be from joint fluids where you're taking a needle and you're pulling that fluid away from the source, and then we're culturing that fluid. Swabs are generally the preferred method of collection. Most are going to have a preservative in the tube, but we still want to get those to the lab as soon as possible. If the doctor suspects an anaerobic organism, or if the specimen is from a site on the body that could contain anaerobes, then we can use an anaerobic swab. So you want to make sure that anaerobic sites are collected and preserved in a manner that would maintain the integrity of the sample. So they're just made in a way that once the sample is collected and then the swab is put back into the tube, it kind of seals it off so that air is not getting to the sample. And then again, clinical information. So we have to know the site of the wound in order to determine appropriate media to set it up on, as well as what could be a pathogen versus contamination. And then we also want the collection date and time. For a gram stain to be put out in conjunction with the culture, we prefer 2 swabs, and that's just so that one can be used for the gram stain, one can be used to set up the culture, so we don't want to contaminate the culture. And then the gram stains, again, just like we've talked about previously, the gram stains are going to give the doctor an initial report that will help them to guide treatment. And then media that we set these up on, it can depend on the specimen source again, and is there a possibility of recovering anaerobes or not. So the media inoculated depends on the source. Most commonly though, wound cultures are going to be set up on your blood agar plate, a chocolate, an EMB or the McConkey, and then a thio broth. And then if an anaerobic organism is possible, we would also add to that your anaerobic blood agar plate and an anaerobic thio. But again, if the doctor's suspecting some fastidious organism, and I'll just use gonorrhea as an example, we would need to know that, because we would not normally set that culture up on media on a plate that would recover gonorrhea. Okay, incubation time. So they get incubated at 35 degrees Celsius, just as normal any other culture would. Most wound cultures are going to be held for 48 hours. So we can send that preliminary report out usually after about 12 to 16 hours of incubation. And if there's an organism that we consider or we think might be a pathogen, we can put that, in the notes to the doctor that we're working on a gram-negative rod, or we're working on a gram-positive cocci. So that kind of gives them an idea of what's happening. But if the plates are not growing anything at all, at 48 hours is when we would report that out as no growth or no pathogens or whatever. And then 72 hours would be for the anaerobic plates. Anaerobes tend to grow slower than aerobic organisms. So, and that would just kind of depend on your lab's policy, whether you hold the anaerobic plates for a total of 48 or 72 hours. The anaerobic plates have to be incubated anaerobically for 48 hours, though, before you can start working on them, and that's just because they do grow slower. So normal flora versus pathogen, again, you have to be aware of what you're looking for, and that depends entirely on the specimen source, which organisms you might be looking for. So it's very important in wound cultures to know the source of the wound, under what conditions was it collected. So was it collected in surgery, which is supposed to be a sterile environment, or was it collected in the ER? Is it a foot? They swabbed the bottom of somebody's foot, or have they taken this patient to surgery and collected a piece of tissue from the foot? So all of those things would be considerations when you're looking at the organisms that are growing on the plate and trying to decide if it's a pathogen, or is it normal flora, or is it a contaminant. Growth in the thio broth. So all wound cultures should also include the inoculation of that thio broth, because thios can help us kind of catch some organisms that maybe the plated media doesn't hold on to. So you can look for growth in the thio, especially if there's no growth on the plate. So you set up your wound culture, you inoculate it, the next day you come in and you're reading the microplates, and you pull up this wound culture and there's no growth on the plates, but look at your thio, because if you have growth in the thio, it is possible to recover organisms from the thio that won't grow on the blood auger plate. And it's not that there's any kind of magical ingredient in the thio that's not included on the plates that's enhancing the growth. It's just that if the organism was present just like in a small quantity, it might not show up on the plates. But if it's being inoculated in that broth, and it's kind of, you can think of it kind of like a slow cooker. So it's sitting there in this perfect environment that would enhance growth, we may be able to recover organisms from the thio. But in order to do that, we would have to subculture the broth in the thio to a blood auger plate in order to get those colonies that we can then work from, do testing on and determine what the organism is. Some of the common pathogens that we recover from wound cultures, Staph aureus is probably the most common, Enterococcus, Group A strep, E. coli, Klebsiella, Pseudomonas. So those are some of the most commonly recovered isolates from wound cultures, but just keep in mind that you can recover just about any organism that you can think of from a wound culture, depending on the source. Okay, so that is the end of this first little section of lecture from Unit 4. The next lecture will get into the non-fermenting gram-negative rods.